Assalamualaikum warahmatullahi wabarakatuh. My name is Syairah Afika binti Subri. My number ID is 012023091933. So I present a case study about fascicular ventricular tachycardia in a COVID-19 patient. Okay, so the fascicular ventricular tachycardia, FVT, is a specific type of idiopathic VT that originates from the left ventricle of the heart. It is often seen in young, structurally normal hearts and is generally considered a benign arrhythmia, which the attack can be precipitated by exercise, excitement, or infection. So the FVT arises from the His-Purkinje system of the left ventricle, particularly the left posterior fascicle, and less commonly the left anterior fascicle. ECG appearance, it is typically represented with a wide complex tachycardia with a right bundle branch block pattern and left axis deviation. So the primary mechanism is re-entry within the fascicles of his Purkinje system, leading to a rapid organized ventricular rhythm. So through this case study, a rare clinical presentation of a moderate COVID-19 infection accompanied by a fascicular ventricular tachycardia will be discussed. The case presentation, a 29-year-old man presented to emergency department with worsening palpitation, pleuritic chest pain and tightness, as well as shortness of breath, mild cough and fever. The palpitation started a day earlier and the other symptoms began a few hours before his visits. He reported recent contact with COVID-19 patient and had not been vaccinated. He also had no history of similar symptom or fainting. So the chief complaint, the worsening palpitation, and the previous surgery, he had no history of similar symptom or fainting. So on the examination, the blood pressure is 120/80 mmHg. The pulse is 182 bpm, which is the higher pulse suggests the tachyarrhythmia. The oxygen saturation is 96%. The temperature is 38.5 degrees Celsius, which indicate fever. And so lastly, the lung auscultation reveal the abnormal crackling sound on both sides, which indicate the fluid accumulate, suggest the COVID-19 pneumonia. This is first ECG in the case study. So the finding including the sustained monomorphic wide complex tachycardia, which is the QRS complex is uniform in shape and lasted more than 30 seconds. Then the QRS complex is 180 ms. The heart rate is 182 bpm. No capture of fusion beat. So it shows the RBBB pattern, which is the RSR pattern at V1. So in this case, the patient was diagnosed with wide complex tachycardia that is caused by COVID-19 pneumonia without further investigate the type of VT. Let's we move to the ECG2. Okay, so after performing the carotid sinus massage and administered intravenous adenosine, the ECG showed no changes, which is ineffective. Subsequently, the patient was administered with intravenous amiodarone, which led to decrease in heart rate from 182 bpm to 120 bpm with resolution palpitations. However, the ECG continued to show a ventricular tachycardia rhythm, so that the patient was then diagnosed with the fascicular VT based on the ECG findings of wide complex tachycardia, right bundle branch block, left axis deviation, and failure to restore sinus rhythm despite amiodarone therapy. Okay, so then the patient was administered with the intravenous verapamil, which is successfully terminated the arrhythmia and restore normal sinus rhythm in less than 1 minute, which strongly proved that the patient had fascicular ventricular tachycardia, or also known as verapamil sensitivity. The patient also undergo the blood test, and the result including the leukocytes with lymphopenia, elevated serum C-reactive protein, which is CRP level, and slightly elevated troponin levels. Okay, so firstly, the leukocytosis with lymphopenia. COVID-19 can cause lymphopenia because they specifically target and destroy the lymphocytes, which are responsible for the immune system. Then, the elevated serum C reactive protein indicate active inflammation and bacterial infection. And lastly, the slightly elevated troponin level indicate the cardiac injury or stress. Then the patient's chest radiography showed bilateral pulmonary opacification, which means both lungs area increased density or cloudiness, which strongly suggests the COVID-19 pneumonia that can cause the pleurotic chest pain. The patient may feel a sharp stabbing pain in the chest because the pleura, the thin layers tissue surrounding the lungs, become inflamed or irritated. As we discuss about treatment and management, like I said just now, from the ECG, the treatment for this FVT is verapamil administration. So the patient was discharged after a few hours of observation and was prescribed long-acting verapamil for 1 week. Cough and fever were worse during the 1 week follow-up and resolved completely at the 2 week follow-up. COVID-19 serology test showed positive results a few weeks later. Let's move to the SWOT, which stands for strength, weakness, opportunity, and threats. Okay, so firstly, for the strength, the patient was accurately diagnosed with FVT based on the ECG findings with wide complex tachycardia, RBBB pattern, and LAD. So the intravenous verapamil successfully restored sinus rhythm, demonstrate knowledge on specific treatment of FVT. The weakness, it including the initial treatment like vagal maneuvers, adenosine and amiodarone fail, prolonging the time to restore sinus rhythm. Then the association between COVID-19 and FVT remain unclear with the limited supporting evidence for causation in this case. Further opportunities, promote the use of verapamil in similar cases when FVT is suspected. Then this case study highlight the need for further research into the link between the COVID-19 and arrhythmia like FVT. So lastly, the threats. The FVT could be diagnosed as SVT, which is supraventricular tachycardia, or other arrhythmia, delaying the proper treatment. So the misuse of verapamil in non-FVT case can cause the precipitate cardiac arrest. For the conclusion, to conclude this case study, the association between COVID-19 and fascicular VT remain unclear, with limited supporting evidence for causation in this case. However, in some studies, COVID-19 can cause myocarditis, which is the inflammation of the heart muscle. It can damage the Purkinje fibers or the electrical conduction system in the heart. So this damage can lead to re-entrant circuit, a mechanism response for FVT. Even in a healthy patient with no other risk for factor, the infection itself can trigger the arrhythmia. So that's all from me. Thank you.